Good evening, everyone, and namaste. A very, very warm welcome to our annual patient safety webinar. Every year, we try to do something around the World Patient Safety Day theme, and I'm very sure all of you had celebrated your World Patient Safety Day in your respective hospitals. And today, I am privileged to be bringing three experienced healthcare professionals to talk about different topics on the topic of pediatric and neonatal safety. So it gives me immense pleasure to introduce all of them. May I request Renika also to be on the screen? Okay. So just give me a second. I will pull up the present. I've got a slide just to show. So I hope you can see. All of you can see my screen. Can you confirm?
Yes, ma'am.
Yeah. Yes, ma'am. Yes, ma'am. That is Dr. Rajesh Shah. He's the group head of medical operations at Hospital Jaipur. And I'm so very grateful, Dr. Rajesh, for being here today, taking time out of your very busy schedule and willing to be here for 2 hours. Thank you so much for that.
Pleasure
And
is mine.
uh,
Thank you.
and the earlier position that he has held is already on your screen. And I have met Dr. Brajesh some time ago at Jaipur, and I found him to be very, very passionate about patient, patient safety, everything around, patient. He was very, very keen. And so his reflection on patient safety is not doing any harm to anyone. So, a very warm welcome, Dr. Brajesh Sa, and thank you very much for being here. He will be our first speaker. And next, we have Professor Dr. Elizabeth Workey. She's the Chief Nursing Officer at Baby Memorial Hospital, Kozhikode. And I have known Elizabeth for a very long time. And again, another passionate person, very there all the time, ready to do anything that comes her way. She's a multitasker, and I hope she will continue to multitask so that we all can benefit from that. And she started her career as an intern, then into college. One of the one of the rare, there's some echo. Just Elizabeth, one second. I need to mute people. Okay, now I'm good. Okay. Are you able to see my screen?
Yes, yes,
Yeah.
perfectly.
Okay. So she's done her masters and PhD in pediatric nursing. So we can meet anyone better than her to speak about the piece. And Dr. Rajesh is going to talk about the vulnerability in this group. And her reflection, care with caution and heal with passion. What a good tagline, Elizabeth. Lovely. I think every step that we take in healthcare must be with caution because we know that one misstep, it can harm our patients. So thank you very much for being here and a very, very warm welcome. And we have our third speaker. She's a young leader. She's currently clinical nurse manager, Mother and Child Hospital, and she's pursuing her master's in pediatrics. And for her, patient safety means protecting patients from harm while they are receiving medical care. Patients need the right treatment at the right time. So each one of us carry our own view. And Renuka ji has been one of my students few years ago, and she's currently assistant chief of nursing at Continental Hospitals, Hyderabad. Thank you, Renuka, for saying yes. And what's her specialty? Why is she here? She's an entirely neonatal nurse. This is what I heard from her. So we'll be hearing about neonatal safety from Renuka. Thank you so much to all my three invited speakers. And I think we have got a good combination. And without any further ado, I'm going to invite Dr. Rajesh to carry on with his presentation. So, shall I share?
Yeah, please, ma'am. Thank you so much.
Just give me a second. The screen is visible to everyone. Yeah. Dr. Brajesh, you can see the screen?
Yeah, ma'am. Thank you so much.
Okay, please go ahead. And when you want to move on, you just tell me next.
Sure, ma'am. Sure. Thank you.
Thank
Thank
you.
you. So, good evening, all, and very welcome to this pediatric and neonatal safety webinar. I extend my gratitude to Tankam ma'am for giving me this opportunity to share my ideas with all of you. So we have learned, we have heard, we have even practiced about the, from NABH or JCI, about the vulnerable group of patients, their special needs, their assessment, their care, their, what, how do they distinguish from the patient population, and how we can, care more to them, so that so they do not get harm and abuse from the system. But today I want to present the same concept, but in a little different way, and particularly more focus for the pediatrics and neonatal group of patients. So the true meaning, next, I would request, next, ma'am. Furthermore, so the true meaning of identifying the vulnerable patients is to recognize and provide a tailored care to individuals who are more susceptible to harm or exploitation due to their physical, psychological, or social circumstances. This practice moves beyond the standard protocol to address the specific risk and needs that prevent these patients from achieving equitable health outcome. And this is not limited to the just permanent labeling them, but it's a continuous contextual assessment that triggers necessary safeguards and support. And this actually our ethical responsibility to protect those with the diminished autonomy and ensure they receive the best possible care. Next one. So recognizing this diverse category of vulnerability, I have, we have the list of vulnerable patients with us from the any accreditation books, but I have just little bit them grouped in a different manner. So first, I would say that vulnerability is not a monolith concept, right? So instead, it encompasses a wide range of patient characteristics and situations. So if we talk about the physical factor, in physical factor, we have age vulnerabilities like patient who are children who are under the 12 and older who are more than 65 years of age. They are often less able to advocate themselves and are at higher risk of abuse, neglect, and accident like falls. Second category is physical disability or illness, condition that causes limited mobility, impaired senses, or complex chronic illness like cancer, heart failure, or HIV. It makes patients more dependent and less able to navigate the health system. Last is the consciousness, altered consciousness. So patients who are sedated, comatose, or recovering from anesthesia are physically unable to protect themselves from harm or exploitation. If I talk about the psychological factors, so mental health, patients with conditions such as depression, schizophrenia, or cognitive impairment may have a difficulty in understanding information, communicating their needs, or recognizing dangerous situation. And emotional states like individual experiencing high anxiety, intense pain, or distress can have their judgment clouded and may be unable to make autonomous decisions. The lastly, social and systematic factor, which is also very unique in nature. Socioeconomic status, like patient with low income, inadequate housing, or who are homeless, make lack reliable access to care, transportation, even or nutrition, which negatively impact their health. In social and systematic factor, the language and cultural barriers are also very important. Limited language proficiency or a cultural difference, they can create the communication breakdowns with healthcare provider, affecting the quality of care and informed consent. And the very special group, which is minority status, racial or ethnic minorities, even migrant workers, and nowadays this LGBTQ plus individuals, they can experience social stigma and discrimination that creates additional obstacles to care. Power dynamics, definitely institutional or differential vulnerability can affect the prisoners, military personnel, and even some patients in a doctor patient relationship, make them reluctant to voice concern out of fear or retribution or a desire to please. So this is all about the vulnerable patients as a group. Now we'll talk about a very specific group of vulnerable patients who are pediatrics and neonates. So pediatrics and neonates patients, they represent the one of the most vulnerable population in hospital settings. Why? Because their unique physiological and developmental characteristics. So why they are more vulnerable? Because of their physiological immaturity. Their immune system is not properly developed. Their vital organs like liver, kidney, they are not properly developed, and even they are not able to control their body temperature by its own. So it all this makes them highly susceptible to infection, complication, and treatment related side effects. Next, ma'am. They are entirely dependent on the caregivers and healthcare staff. Now, like unlike adults, they cannot clearly express their pain, discomfort, or specific needs, which often delays early recognition of problems. And this communication barrier puts extra responsibility on staff to be more vigilant. Another critical factor is medication safety, which is very crucial. The drug dosage for children are weight based or surface area based. And even a small error in circulation can lead to a serious harm because of their narrow safety margins. Right? So, in hospital in India, a prospective observational study over a 4 months have done it, and it found that medication error in 10.5 patients of pediatric population, and this and the highest rate of errors which was in children under the 2 years, which is very horrific. And the last one is similarly procedures like IV therapy, ventilation pose a high risk in this fragile body. And if I talk about the psychological perspective, the hospital environment itself can be a traumatic. Separation from parents, exposure to unfamiliar surroundings, and repeated intervention, it can affect their emotional well being and long term development. So finally, because they cannot give the consent for them their own treatment, they are ethically and legally dependent on patients and the healthcare team, which further emphasizes our responsibility to ensure safety, accuracy, and compassion in every aspect of their care. So now we talk about the specific risk to this vulnerable group of category. So risk to the pediatric and neonate patient in healthcare settings are very unique due to their size, developmental stage, and dependency on caregivers. These vulnerabilities create distinct risks that differ from the adult population, particularly concerning the medication, infection, medical devices, and communication. So now if I talk about next, ma'am, if I talk about the medication risk, higher risk for medication errors due to the need for the weight based dosing. This require precise calculation that are prone to human error. So, if I give an example of one particular, medicine which is concentrated electrolytes, such as potassium chloride, sodium chloride, or magnesium sulfate, they are potent solutions and intended for dilution before administration. However, their high concentration poses a significant risk if administered directly or inappropriately. So this example was is quoted in the JCI, this sixth, seventh, eighth edition is this solutions should not be stored even a patient care area unless absolutely necessary or only after a thorough risk assessment. So what happened in Canada? Two fatal cases in pediatric were reported where concentrated potassium solutions were mistakenly used to flush intravenous lines or administered excessive amounts due to miscalculation, leading to severe hyperkalemia and cardiac arrest. So this kind of major harm can happen if we don't give attention to this dose calculation. Second is the off label uses. So many drugs are not actually approved officially for the pediatric use, but in many care settings, many medicinal solutions are used, and which actually leads to which doesn't have the standardized dosing pattern, and which leads to the patient harm. Third one is a formulation issue. Administering a liquid medications can be a challenge, because if in household spoons where the appropriate measuring device is not available, that can lead to the inaccurate dosage. And the last one is limited tolerance of error. So small calculation mistake can have a large impact on child's small body, potentially leading to an overdose or underdose. So in our general practice also, we over a period of time, by experience or a skill, we uh, usually do not calculate dose exactly. While over a period of time we get some kind of estimation that this is the dosage which a particular body weight is needed. So but this is not acceptable in pediatric and neonates, where absolute calculation, proper calculation is required for a dosage purpose. So these are the medication safety challenges for the pediatric and neonatal group. Next is infection risk. So we know that hospital settings are a very compromised environment, and patients are always immunocompromised or have their comorbidities. So their immune system is not properly guarded for this hospital against the hospital acquired infection. So children, neonates or pediatrics, they are more immature. They their immune system is not properly developed, which makes them more susceptible to the hospital acquired infection. This infection can be more severe in children, and many lead to a prolonged hospital stay or death. So common HAIs in pediatric populations are central line associated bloodstream infection. These are a major risk, particularly for the premature infant and those who are into admitted in neonatal intensive care ICU. They often require central venous catheter for extended period. So CLBSI can happen. Next is VAP. This is significant concern for children on mechanical ventilators, as their underdeveloped airway are more prone to infection. And third one is surgical site infection. So because of same immature immune system, children undergoing surgical procedure, especially with those with the comorbidities, are at increased risk of infection at the incision site. The third one is the medical device related risk. So this is also very unique in nature. Medical device designed for adults can pose significant risk to pediatric patient. Children's smaller and more delicate body, can be easily harmed by inappropriately sized or placed equipment. So, medical device related pressure injury, first one is, these are major concern, especially in premature infants. So, device like, we know that endotracheal tubes, feeding tubes, even a pulse oximeter can cause serious skin damage or pressure ulcer due to constant pressure on their fragile skin. Second one is chemical exposure. Studies have shown that some medical devices such as catheters, syringes can contain chemicals like BATH, which may pose a health risk to developing infants. And last one is a physical injury. Devices can cause physical harm if they are not properly secured or are too large for their patient. For example, IV lines can easily be dislodged, leading to infiltration or extravasation, lead to the phlebitis, while improperly sized cast or braces can use the nerve damage or blood flow restriction. Next one is the very important communication gap. Communication gap are the leading cause for medical errors in patient population as a whole, but they are particularly problematic in pediatrics due to involvement of multiple caregivers and family members. So what happened when information gaps happen? it is common for a child's care to be managed by the multiple doctors, nurse, and specialist. So, a failure to adequate transfer of information during handoff, it leads to misdiagnosis, repeated test, and treatment delay. Next one is parent communication. Parents role is very crucial in child's care. So if they do not understand their the terminology or their risk or outcome properly, even language barriers are there, or simply the stress because their child is in a very compromised state, is not healthy, so their mental capacity to understand all the things which is compromised, so it leads to a communication gap. Then limited patient feedback. Unlike adults, young children and infant are often cannot clearly articulate their symptoms or pain. And this makes it essential for healthcare provider to rely on careful observations and effective communication with caregivers. So, but it also creates risk of misinterpreting the child's condition. So, creating a holistic safety net for vulnerable patients, particularly children and neonates, require multifaceted approach that addresses not only clinical risk but also the social development and environmental factor that contribute to their vulnerability. So this involves creating a collaborative system that extend beyond the hospital walls. So next, ma'am, first we'll identify what are the strategies that we can build into the hospital setting itself. So a robust hospital-based safety net for vulnerable patient focuses on a specialized care, communication and technology, specialized training and staffing. So what it includes is healthcare professional caring for the pediatric and neonate patients must have the specialized training. So there even resuscitation training for like PALS or NALS, which is also required. This include weight-based medication dosing, recognizing subtle signs of distress in non-verbal patients, and identifying signs of abuse or neglect. Even higher nurse to patient ratio is also very important in this uh, pediatric and neonatal age group, because timely intervention and more vigilant monitoring is required. So for that, ratio is also sometimes different. Then structured communication and hands off. We know the importance of handover is very much crucial for even between doctors to doctors or nurse to nurse. So it should be a very standardized format, which is ISBAR format: identification, situation, background, assessment, and recommendation. During patient handoff can reduce the information gaps and medical errors, involving involving parents and caregivers in this discussion ensures they are informed partners in care. So this is very important, structured communication. Now even this leveraging technology using EMR, electronic medical records, health records, which is built in clinical decision support system, which can flag the potential medication errors such as incorrect dosages or drug to drug interaction. And even a centralized patient monitoring system can provide the real-time alerts for the changes in patient vital signs, allowing for the rapid response. So these are the hospital-based some strategies which we can develop. Now, for the holistic collaborative care approach, a truly effective safety net extend beyond the medical and technological aspect to incorporate the child's entire well-being. Now, for that, what we have to do is integrated care team should be there. Which are the members should we include? So, all like doctors, nurses, social workers, child life specialist, and even a psychologist. So, this kind of approach is not in everywhere in Indian, healthcare settings, which we have to develop. So they work together to address not just the patient medical needs, but also their emotional, developmental, and social circumstances. Second one is the patient and family empowerment, which is very important. Empowering means not giving them rights, but they're giving them proper education, resources, and emotional support. They should be seen as a key member of care team. This partnership helps ensure continuity of care, especially even after the patient leaves the hospital. So this vulnerable group, they cannot be limited to the patients because of their age limit, because we are considering that a patient under the 12, till that time they are vulnerable. So not only the hospital settings, even the atmosphere at their home and society also very much important to prevent them from them harm. Community based partnership, hospitals should forge strong partnership with community based organization. This network can provide crucial support for families, including assistance with housing, food security, and transportation. So connecting vulnerable patient with these resources ensure their basic needs are met, and which is fundamental to their overall health and safety. So this is the holistic collaborative care approach which we are providing. But I also want to discuss about the addressing the social determinants of health. So what happens, if we do not understand that what are the root cause for the vulnerability, we won't be able to address them properly. So for that, what is required is universal screening, a policy or advocacy to a government or a healthcare organization which make them more available, more accessible to the health insurance, funding for the social safety program, initiative that combat the poverty and inequality. And the last one is a proactive outreach. So instead of waiting for the crisis, healthcare system can implement proactive outreach program. So our government has already started that. They have created Anganwadi worker or Asha's worker. They go to the door to door and they identify their needs for the education, their local services which are the available, and how they catch them before they fall into the state of the acute vulnerability. So these are the approaches we should focus on it, right? So in the end, I would again reiterate that true patient vulnerability, ma'am, previous one, previous slides please. So patient vulnerability identification requires holistic, patient-centered approach that recognizes a diverse risk and address them with empathy, which is very important, customized support, and careful safeguard to ensure equitable outcome for all. So this is it from my side, which actually says that uh, vulnerability is really concerned, but the group which we are right now addressing, pediatrics and neonates, are more dealt with the empathy and very much attention for the care. Thank you, ma'am. Thank you all.
Thank you. Thank you, Dr. Brajesh. I think you have given a totally new perspective to the word vulnerability. It is not only related to the age or certain definitions that is given. You have gone beyond talking about understanding their, economic background, where they stay, how they live, how much they are educated, can they understand. So the word vulnerability is, by and large, you ask anyone, they would say, I have to prevent the patient from fall.
Yes, ma'am. Yes.
So I think the intent here is to sensitize everyone who is here today. Thank you for being here, and also those who are going to watch this recording, to understand that vulnerability is not just limited to a red band or an orange band, and also just thinking we have to prevent patient from fall. There are many more aspects to that, and Dr. Rajesh, thank you so much for throwing light onto that. And I would request all our attendees, if you have questions, please keep putting it in the chat box, and any comments. So we will take all of them together at the end. So now we move on to Professor Dr. Elizabeth Workey, where she will be dealing with the six P's of, you know, pediatric and neonatal safety. And it's an interesting way when you listen to Dr. Rajesh and when you're going to listen to Dr. Elizabeth Workey, both together, it itself is a very powerful session for you to understand pediatric safety. Then, and adding on to that will be the neonatal safety aspect from Renuka. Over to you, Dr. Elizabeth Workey, and thank you very much.
Thank you, ma'am. Thank you so much for this opportunity. So, as we all are celebrating the World Patient Safety, especially concentrating on the vulnerable population, basically the patient and patient safety. So, here I will be presenting a small topic on 6 P's of pediatric safety. As you all are aware about, the pediatric safety is of various concepts and various parameters that we do. So, I just want to put this pediatric safety into pediatric safe, which means pediatric and every child deserves safe family engagement. So with this note and as an introduction, let me move forward. So this is 6 P's of pediatric care. The first P goes to patient-centered care. Second P is parents and family engagement. Third, physical environment. Fourth, professional competence. Fifth, psychological safety. And finally, the sixth one is process and protocols. So moving forward with all these P's in one by one. So the first P states that the patient-centered care. So we have to place a child first. So every child is not a small adult. They're unique, delicate, and even they deserve much care. So with this in view, the child has been centered as a person to be cared well. So this pediatric physiology is different, as you all know that, as doctor has also mentioned about the medication dosages. The minor error even creates patient safety concern. The fluid balance, nutrition, even the respect, dignity, rights, and comfort of every child is also important part in this patient safety for considering the child as a unique personality. Even the developmental stage, we have to consider the communication, whether it is tailored to the age also. So first and foremost, we have to keep the patient or the child as the first priority, and centered care should be there. So here are some best practices that we can adopt when we consider the pediatrics. So we are hearing about the various consent forms and all. So some best practices is like some pictures and storybooks for MRI exams. So here we have seen that in one of the hospitals, it has been followed in Apollo, I think. So they have seen this. This is like a storybook where the MRI, the process of MRI, is been narrated well in the form of a story. So it is a little roti of how it has been entered, and a little tunnel is explained. So this makes the child uh, much more comfortable, and where we consider their own limitations. Then moving like the some child-friendly consent and assent also. So here's some kind of assent, like where we will be explaining to the patient or the child about what is going to be done. So this is just a sample example to see that how the researches has been done and how the videoing, especially in playing with the kindergarten, has been done. So this is a consent which has been adopted for the pediatric lens. Such kinds of some best practices could be adopted to feel that these children are the vulnerable patients, are the unique people, and they are given the first priority. Some other best practices like use age appropriate communication tools like toys, pictures, child friendly consent, and some pediatric specific protocols, especially for medication safety. I think you might be aware about this Broslow pediatric chart where the medication safety is being followed, as well as especially in the times of crisis, emergency. And here we can see that some other best practices like we provide with the toy syringe on a teddy bear. This is how we explain to them. We consider them as a small, younger, vulnerable population, but considering them as a unique personality, considering them as a unique person, such kinds of interventions helping them to understand what is the procedure to be done, and that how we make them comfortable also. And even some customized trolleys or customized kinds of trays and design, because I've seen in many hospitals, some hospitals I've seen some best practices that they have customized the trolley in the form of a jeep. So when a nurse goes to give some medications, see, they put a horn over there like a jeep, and the children are so happy to receive the nurse with such kinds of customized jeep, which is actually the trolley of medications. So this kinds of some innovative technologies will help us to understand the patient as well as this vulnerable population, thereby helping them to be very safe and free from any fear and anxiety when they're admitted in hospital. So going to second P, it says that parents and family engagement, because parents are the partners in protection. So a safer child is one cared by a family and a team together. So we should have this parents and family engagement as a priority protocol or priority aim when we take care of the pediatric client especially. So we will be get to know know the families, the meaningful involvement of the families, and even the relationships also we can see it will be enhanced. So here, some other things we can include is parents are the constant caregivers and advocates. So involve them in the care, especially when you plan, when there's any safety checks or if there is a discharge teaching, the parents has to be involved and ask them to come up with questions, queries. Normally, what we see is that when a parent comes with the questions, or we are not given such much importance to what they have their anxiety or what they wanted to add in patient care. So the parents are being considered as the third eye for the child. So they because when the health team members are taking care of the patients, we may be missing many of the minor errors or minor symptoms of the child. Whereas a parent who is there with the baby or with the child, the pediatric client, they'll be able to identify the minor changes of their child. So this will be helping them, helping us to consider their concern, and this will be helping for better patient care. So some best practices like bedside safety rounds with family. So many times in this what to say this present scenario of patients, or when there's a lot of engagement of patients here and the busy schedule and all, we forget to involve the parents or the family members in the care of the child. So this rounding with them and explaining to them what are the concerns and safety practices, especially to encourage speak up for the safety, parents can voice their own concerns. And as I mentioned, they can ask the questions, teach parents about the safe sleep, feeding, fall prevention, and how to monitor for any minor changes of symptoms. And one more thing that is specifically in this present generation as well as the present scenario is coming up is known as parental fubbing, or basically we call it as a maternal fubbing. So this maternal fubbing implies that the mother is completely concentrating on the mobile phones, ignoring the child care. So with this, we have seen that plenty of patient falls, especially the pediatric falls, are also coming up. And one study was also conducted in our hospital, and we have identified that this paternal fubbing is one cause for the child fall. So we have to give the proper explanation or the proper teaching to the parents about this maternal fubbing and its impact and the side effects for that. Moving to the P3, which is the professional's competence. So any person who is caring for the child, they should be the prepared hands and the protected lives. So competence saves complacency risk. So what we mentioned is that there should be specialized training, especially in neonatal and pediatric care, because it's a crucial part. And there should be continuous skill upgrade, especially in resuscitation, infection control, pain management. And any wrong or delayed diagnosis is causing prolonged illness, disability, or death. So this is a major concern which is highlighting in the present scenario. Like there are wrong or delayed diagnosis of the patients who has been admitted. So this is causing prolonged stay of the patients in the hospital, as well as causing many other death and disabilities. So they should be given age-specific competency. They should be trained in the various aspects of patient care, especially the pediatric clients. So some best practices like some simulation-based training for rare pediatric emergencies and competency validation annually, especially with the medication calculation or CPR and some other minor procedures, and use of various advanced technologies also we can come up with. So you all know that there are certain kinds of new advanced technologies where there are vein find, and also this, I think you will be familiar with this vein finders going up. So with these things, we can improve their skill. They will be able to much more concentrate on their the parameters of how to take care of the patient, or it will be creating a kind of uh, less stress as well as distress for the patients who are sick. So this is some kind of things that we can implement with. So moving forward, the fourth P states that the process and protocols. So there should be systems to save children. Safety is not just luck, it's built into systems. So in this, we say that there should be some standardized protocols to prevent variation as well as to an error. Sometimes we can see that when errors happen, we do the complete RCA and we come up with various processes of there. But sometimes we are reluctant to unlearn certain things. So try to unlearn certain aspects which is not appropriate for the care of the baby. Instead, learn the best things. So you will be using some safety pediatric bundles like VAB, CLAPSy, and medication safety. The equipment safety, especially nowadays, we are occupied with so much of equipments, especially the infusion pumps or some other forms of BiPAP. So these are some areas where we have to have the concerned that this has not been backed up. So the backup battery will not be sufficient. So that is causing certain kinds of fatal conditions for the patients even. So there should be much, as a health professionals, we should be much more vigilant on these kinds of areas, because we are not that much giving importance to such areas of equipments and their management. So that's a very important area that we have to keep up with. So some best practices like implementing that pediatric early warning score, which is the PUs, using of checklists for surgery like WHO safety surgery for children, and barcoded enabled medication administration. So moving forward to the fifth P, that is the physical environment. So safe spaces for small steps. So a child's world must be risk-free inside hospital walls. So this, as doctor has already mentioned, that the pediatric client is having the anxiety when they enter the hospitals. So the physical environment should be so soothing for them that they will not be facing with such challenges or anxiety or pain. So there should be child-friendly, hazard-free wards to reduce accidents. I've seen in some hospitals what they do is like when there is a Christmas, when there is some other celebrations, they bring up with certain kinds of smileys in that, and the child is being attracted to it. So they'll be making some kind of what to say, some the Christmas father is being made to stand there. So they're making them so easy to be in that environment. So this kind of best practice can be followed. So noise, temperature, infection control is a must, and it will be affecting the recovery also. So some best practices like soft flooring, rails has to be upped, child-proof electrical sockets has to be implemented, and strict infection prevention. That's always emphasized, like for the hand hygiene and vaccination of staff. Even to minimize radiation exposure with pediatric protocols, and ceilings also, some night skies. Some pediatric wards or some hospitals, they have built up the ceilings in such a manner that when it is the light is switched off, they can see that platinum kind of lights coming up, and the child becomes so easy while sleeping, and they can see these galaxies in the sky. So such kinds of innovative technologies can help them to come up with the best environment where they can survive. Moving on to the last six, P is psychological safety. So healing beyond the body. So a calm mind heals a fragile body. So the psychological safety is an important aspect in which the emotionally secure, respected, and free from, they should be free from fear of humiliation. Because as you all know that the pediatric line, any pediatric patients are afraid of the injections. And even the parents also say that if you don't obey or if you don't have the food, the nurse will come and put the injection. So this is kind of humiliation that they face. So they should be free from all these kinds of emotional insecurity. This hospitalizations cause fear, anxiety, and trauma in children. So there should be some supportive aspects where that we can make them ease to the environment, especially the psychological safety for the parents too. So that will be reducing the errors and builds trust. And one important aspect which is coming up now is the paternal postpartum depression. We are always, the previous years and all, the most of the time the talks are on postpartum, maternal postpartum depression. But here is a need for understanding what is a paternal postpartum depression and how the parents, especially the father, can help in rearing the child when the child is being born. So this psychological understanding their psychological aspects is a very important area where the light has to be thrown into. So this many times we can see that if the parents are healthy or mentally or psychologically healthy, the rearing of the child also will be taking part in the best manner. So this aspect of paternal and maternal psychological health also has to be kept in mind, and the proper care has to be given. Some best practices to make the child in ease and to have the psychological support is like you should have a honest communication with the child and the family. Like if it is going to be paining, or if you're doing some procedures, you can explain to the child as well as the parent about its impact. Some play therapy, music therapy, even some pet therapies are also being undertaken. Some evidence-based practices say that the pet therapies heals a child and it makes the child much more like free from any anxiety or stress when they're hospitalized. Now, zero tolerance for blowing or blame in the pediatric care teams, and evidence-based practices like application of BUS. This is a one kind of best practices which has been followed in some hospitals, and in our hospital also has been followed. This is a kind of equipment in which this has a cold pack, and this is kind of a honey. It looks like a honey bee, and it has a switch on it. So it causes vibration, as well as the cold application also stimulates the venipuncture site. So this is like a distraction. At the same time, it causes vasoconstriction, and thereby it reduces pain. So such kinds of best evidences can also be practiced to make the child free from any sorts of fear and anxiety. So this, with this, that we have comes up with six P's of how to care for the babies or the pediatric clients in the hospitals. So to take home, we can just combine these all these six P's into this acronym of PROTECT. So P for patient-centered care or the child-centered care. R is a relationship with the family, parents and family. O is for outstanding professional competence. That is a competency of the staff or the any of the health professionals has to be maintained appropriately. And teamwork through process and protocols. E stand for environment that child's safe. And C for care for psychological well-being. And finally, T for total safety culture. So let this be a mantra in taking care of the patients, especially the pediatric clients, by utilizing this six P's of them. So to conclude, protecting little lives with purpose. So with purpose, passion, and precision. So let this be a mantra throughout throughout our journey when caring for this vulnerable group of population. Thank you.
Thank you, Dr. Elizabeth Warkey. You speak quite fast, so we definitely finish faster. But I think beautifully complemented what Dr. Rajesh was discussing. You know, getting into details, and I'm not a pediatric or a neonatal nurse. I ran away when I passed out from my nursing because I was tiny, 37 kg short. So my nursing director thought you are a good fit for pediatrics or neonate department. So I said, no way, because I found during my clinical rotation, I can't sleep if I'm assigned to this little lives who are suffering. So in the night, I'm just thinking, is God fair? Why is this child suffering? Why did the child get this diagnosis? So I was so emotionally upset. So I decided, no, adult ICU is my cup of tea. And even today, but I know once I became a mother, that's the time I realized that how important it is to understand these little, children and the babies who don't have any voice. And imagine when Dr. Vajesh told that in the parents are not able to verbalize the need of the child or need of the family. You can imagine the kind of trauma they go through, so many unresolved questions and doubts in their mind, right? So I think both of you beautifully complemented what can be done for pediatric and neonatal safety. And so now, please, I'm hoping that all of you are ready with your questions. We will finish with Renuka's presentation, and post that, we will take questions, and I also have some questions and also some thoughts. So we'll come to that, maybe a couple of stories I have got to share. I think I'm clashing Renuka's system. I'm getting echo. Are you hearing echo?
Yes, ma'am.
Yes, yes, we are hearing echo.
Okay, now I will just allow her to start her presentation, and then I'm going off. Over to you, Renuka. You can share,
Ma'am, can I share the PPT?
please.
Okay, ma'am. Ma'am, is it visible?
It is visible. It's on screens. So, Elizabeth, please answer in case he is asking something. Okay. He
Yes, ma'am. Yes, ma'am.
sort of echo. Yeah.
Yeah, a very good evening, one and all, and then very thanks to the Tangam madam who given me this very good opportunity to.
Renuka, your volume is very low.
Hello, ma'am. Thank you. Ma'am, you are hearing?
Little more louder.
It is already full. ఒక నిమిషం. ఇది కొంచెం ఇంకా. Good evening, ma'am. Good evening, and one and all. I'm very glad Tangam madam given me the good opportunity to speak in a forum. I'm taking up this, ma'am, and today I'm going to talk about the fragile beginnings preventing falls and safety incident in the neonatal ICU. Ma'am, hearing?
Your voice is less. Can you just
It
increase the
is,
volume?
ma'am, it is full in my concerns.
Probably you have to see your speaker or you come closer to the system.
Okay. Today I'm going to talk critical importance of preventing falls, well-being for our most vulnerable patients, newborn falls, recognizing patient safety issues. Next, my objectives for today topic: identifying risk factors for fall in NICU setting, explore safety handling protocols and use of technology, strengthen caregivers and family engagement in fall preventing in my thoughts. Let us see incident rates in neonatal, fall incident rates in neonatal. UK NHS reports 2 to 3 falls per 10,000 live birth, and UK 1.6 to 4.14 falls per 10,000 live birth. Canada and Australia reports comparably and 2 to 5% for 10,000 live births. And then wherein India reports 1.6 to 4.5% per 1,000 live births. It is common cause. India is reporting 10 to 20 times higher than other countries, and the most common causes postnatal ward, especially when night mother tired or sedative post delivery, and mother sleeping with a baby on bed without side rails, handling baby tired attenders or relatives, inadequate nurse patient ratio. There are hidden challenges in a fall and prevalence, common causes, serious consequences, understanding, underreporting. Some mothers tired and they will not share the report. They feel shame when they comes to the OPD and they feel guilty. This we have to teach them, and then this may lead to the serious consequences when they are not reporting to the proper. Why newborns are at risk? What are the contributing factors? There are three types of contributing factors: maternal and caregiver related, environmental and equipment, clinical and then procedural. And maternal and caregiver related risk factors: medication effect. When mother is in epidural, post anesthesia, sedation medication she will undergo, and fatigue and then sleep deprivations. And then especially during the night time, it is very crucial post operative 3 days to high risk for the fall. And parental status during breastfeeding session, mother may be asleep while holding the baby, it may be the fall. Newborns already is the vulnerable. There are some unique vulnerabilities are there, like such as preterm, which those who burn low birth weight, as per the we consider as a India, those who birth less than 2.8 kg is the low birth weight baby. Immune system, they are immature babies, those who burn under development neurological and then neuromuscular system, and then frequent handling of the newborn. Equipment and environmental and equipmental risk factors: unsecured incubators, clustered pathway, improper positioning of the newborn. Clinical and then procedural risk factors: when it is come to the clinical, infant transferring, when we are transferring the infant OT to ward, OT to NICU, and labor to the ward or NICU, we have to transfer the baby. When we are transferring the baby, we have to see the wheelchair unlocked and then side rail raised. And handling during the delivery time, especially the mother under anesthesia, soon after we are very excited to give the mother to the baby, and then be careful about the baby. And mechanical ventilation and invasive procedures, when we are doing the in NICU ventilation and then invasive procedure, make sure that warmer should lock, wheelchairs are locked
Renuka,
properly.
can I request you to please speak loudly?
Yes, ma'am, I'm loudly speaking, ma'am. I'm sorry, I'm getting a speaker also, ma'am. You can give me the excuse on this. Meanwhile, I'll carry on.
Okay, because your voice is still low.
And mechanical ventilation
Yeah.
invasive procedures, when we are doing the procedures, make sure wheels are locked and then side rails are raised. And this is the one of the case study scenario. And high risk factors: mother with epidural, holding baby at delivery, immediate parental fatigue, unsecured incubators. Dramatic impact, emotional and then clinical consequences when fall happen. Most falls are happening. It will be injured, major injuries like a scalp swelling and then abruption. But in a severe cases, it leads to the skull fracture, intracranial hemorrhage, long-term neurological issues. Even no injury, fall can cause emotional trauma for parents and then staff in the hospital, medico-legal implications. Recognizing and assessing fall risk in NICU, we have to adopt standardized assessment tools, understanding unique risk factors, and develop common languages. And then there should not be any language barriers between nurse and then parents. We in at a continental hospital, we are doing Humpty Dumpty scale from 0 to 18 years, and we will follow. And we are debriefing form, and family members and then parents. We will clearly debrief the baby. Objective 2: safe handling protocols and technology use in NICU, protecting our most vulnerable. Designing NICU and space for the security and then safety, control entry points, thoughtful layouts, and integrated technology. Wireless sensor: when we are adopting a wireless sensor, when mother comes to the KMC, baby will not get any disturbance. Our mother will not feel that seeing it wires, scared about that. And then we can develop the comfort with between mother and baby with we adopt the wireless. In NICU equipment designed for safety and then comfortable, and temperature control beds, precious monitoring tools, mobile imaging solutions we can adapt, and then we can safe we can make the comfort to the babies. When you advance monitoring, when you are adapting advanced monitoring technology, real time oxygenation, reducing the trauma or any trauma, remoting seizures monitoring, life supporting system. And when ultrasound protocols, treatable emergency guidelines, and bedside ultrasound screening within the minutes, uh, we can reduce the cardiac components, pneumothorax, pleural effusion, aortic occlusion, abdominal emergencies, and then brain emergency for the babies. Integrated protocols and technology to save lives, rapid diagnostic, holistic care, and safe environmental. Coming to the objective 3: strengthen caregivers and family engagement in neonatal fall preventing methods, and a comprehensive approach to safeguard our most vulnerable patients. Why family engagement is a safe game? We If we are giving a tips or tricks to the parents and family members, it will be really real game challenges for the parent and then nurse, and education tools, and then providing the success. Strategies to strengthen engagement and then safety: a standardized risk assessment, hourly rounding and then checking, prenatal and postnatal education, open communication. Visible and then visual and integrated tools for the families. Bedside key cards we have to appear when they are coming to the weekend, they can see the which is the most vulnerable. And teach back method, safety boards, and digital resource. Real stories, if you are near miss, good catches if we'll talk. And then when we have to empower, and reporting near misses and good catches can provide valuable insight into the potential risk, and then help organization improve their safety protocols. Overcoming barriers, building a trust, and then reducing the sim, and then normalize. We have to normalize. We have to uh, wrap the we have to wrap the families to the very helpful, and then normally seeking they can feel, they cannot feel the any communication barriers. We have to feel empathize, and then share some success previously, how premature we have saved the babies, and then we can share them and then cherish. Call to action, parental and then safe neonatals, and then we have to family and then staff educate and then reinforcement them, and then empower the families about the handling of the baby, and then invest strategically and then cultivate learning protocols are vulnerable. Evidence based practice, family engagement, staff educational and environmental control, visible reminders and then algorithms, it can be helpful. Building culture, building culture of safety to prevent a fall in an ICU, we required proper communication, teamwork and collaboration, and continue improvement. Sorry, madam. Yeah. To prevent strategy in India, when we are starting a new NICU, we have to start proper policies and protocols, good infrastructure, and staff and nursing and then staff care, and parental education, and we should encourage the staff reporting incident. And coming to that, my key taking home message: staff vigilance, parent education, and environmental control. This we can 100% prevent the fall. Main risk factors globally: mother exhausted, sedation, holding a baby in bedtime while breastfeeding. And Western hospitals emphasize roaming in safety, base nets, and parental education as strategy. Building culture of safety to prevent NICU fall on organization. Thank you, ma'am.
Thank you. Thank you, Renuka. Can you mute yourself? All right. Thank you. There seems to be pretty good cross connection between Gurgaon and Hyderabad. That's really, that's very strange. Okay. So thanks, Renuka. That was a little bit of a challenge of volume, but technology sometimes can fail you at the most needed time. I understand that. But very good presentation. Please keep yourself muted because while I'm speaking, there's something that's happening. There's a lot of echo coming. So, three of you together kind of have covered pediatric safety. Dr. Rajesh gave a holistic overview of the entire thing from a very strategic point of view. And then Elizabeth dived into the pediatric safety in the form of 6 Ps, and then Renuka specifically talking about neonatal falls. And I'm so surprised that our neonatal fall rates are almost 20 times higher than the other, um, Western countries. But I'm just thinking it has nothing to do with anything, right? Why should so many neonates fall? So that was my major concern when I'm listening to all of you. Why so many neonates should fall? So I just want to hear from the speakers, also any audience sitting here. You can also share that why the neonatal fall rate is so high. One thing that Renuka mentioned was that, maybe there is a little bit of shame attached to admitting that my child fell down when I was with the baby, right? And also the family background, the in-laws, the mother, the father, I don't know who will do what because the child fell down. I think there's a lot more to it than that meets our eye, because that's what I feel, When I was working abroad, neonatal falls, I had one neonatal ICU in the hospital, and I was the ICU supervisor at that time. I have never heard of neonatal fall during that time. I never heard anybody falling. And when I was doing my training, I used to work in the good, what you call as nursery where all the healthy babies used to be kept. Now, no more rooming in concept was not there. All the babies were there every 2 hours. We were feeding, and there we had fall actually from the nurse's hand, because during night shift it takes a lot of time to feed 60 ml of milk, right? So they're sitting like this and it went off and the child just slipped down. So I have seen that. So uh, I'm all ears to learn from all of you. What is this so much of neonatal falls?
So probably, ma'am, I guess the whoever is handling neonates, it's a very tedious and strength-taking thing, even for mother, even for a healthcare worker. So probably they get fatigue or exhaust, and then ultimately, sometimes it happens that they miss the things to give attention properly. So probably this might be a cause, the fatigue or exhaustion.
So isn't it there is a need for the nurses who are in those department to also assist the mother? Is the mother in a state to take care of the neonate? Can she feed? Can she hold? So I think there is an additional need, not only zeroing down on the neonates to say that, okay, I'm going to look at the neonate and their fall risk, but I think there is a, package that is coming that also needs to be, looked into, right? I
So
think
that's an
that's
empowering thing, ma'am. So give them knowledge, give them proper training. This is also part of the parenting, and
maybe
it's
the education should start also from the prenatal time, right? While they come for their prenatal classes, they should be sensitized towards, this, and also making the event
Anka,
of,
may I?
yeah, yeah, just give me 10 seconds. The event of fall shame free, so that they are aware my child maybe can fall, so I need to be careful, or maybe I should ask for help if I am not feeling healthy enough to look after my baby. Maybe these are my thought process when I'm listening to all of you. Yes, Dr. Jyoti Clara, thank you for being here.
Yeah, thank you. Thank you. That was a very nicely presented session by all three of you experts. I really enjoyed. As a nurse with neonatal specialization, and also having worked in oncology, medical, and the burns ICUs of pediatrics in my earlier days, I would say that there is a great shift from perspective of children falling from those time to this time. Earlier days, the fall, of course, what Madam Thankam said is very right. But current days, every fall is considered very serious by the parents as well. They are much more open, at least the educated population, we would say. And because the number of children are also less and they are considered to be very precious. So the reporting I think, has improved over the period of time. And I am not only telling from hospital perspective, I am also telling in reality perspective in the community. The second thing, what I would like to tell you is, especially when the age is very lesser, neonatal, as she said, the training has to happen right from the prenatal period, which is called as a mothercraft program, where they try to carry a doll or a child, and then all that they have to be taught is these all are happening. But I think one emphasis is very important from us, especially when the child grows to like 8 months, 9 months to probably the toddler age, which is the time like they want to explore. So that instinct starts coming up, and by 1 year they start exploring 1 to 3 years. So they don't fear even hitting here there. Sometimes you won't even realize that they have hit. You will come to know later when you see a bump or something. So probably special education on this group of children probably would help, I think, for the parents. And also the consequence based teaching. For example, consequence based teaching is like, what happens if a child falls? It might not influence them immediately because they forget. They immediately something distract them. They overcome the pain. But what happens in the long run? Probably such informations are reaching parents. I think that would help better. And moreover, now the women are working population. I'm talking about the community focus, because our job does not end in hospital. The safety is very important when we educate and send them home. So we have to say who is taking care of the children, either the caretaker, childminder, or probably at home somebody who's taking care of the children. So those are the people who needs more information about prevention of fall and why to report it immediately. So these are few points I thought I would share as
No, no,
complementing
wonderful,
points.
wonderful thoughts, wonderful thoughts. A couple of comments here. Lata is telling never transfer hand to hand the infant, transfer only by bassinet, rather than giving handover through bassinet.
Yes.
Uh, and I also had one more comment was there. The earlier nurses should get special training, agreed. So I think we already discussed Lata mentioning about mothers being drowsy. So nurses need to be trained while they are handing over the baby, what they need to look in the mothers also, right? That's important. But if you only train them how to safely hand over the patient by hand or by bassinet, they may not even pay attention to the mother, right? So there are complete spectrum of pediatric neonatal safety, starting from the educated population to the rural setup. Like Dr. Rajesh mentioned, people who are illiterate coming from backgrounds where they don't have their own voice as an adult, and when they come into the system with the baby, it's even worse. So I think the entire voice of all the speakers here is empowering and educating the parents in their level of understanding. Whichever language they can understand, so they get it. What is the patient safety? And I also want to ask all the panelists, since you are working in hospitals, are we listening to them enough? When the pediatric and neonatal children, when they're admitted, I'm talking about the clinicians, and the nurses who are so busy, are we listening to them enough? Because I know that adult patients, the doctors hardly listen to anything. They are more interested in telling, before you finish the complaint, they have the diagnosis and say, oh, this is what I think you have. You do 1, 2, 3, 4, 5 and see me next week. Finish consultation. And this is, I'm telling, this is even despite the fact I know the doctors personally, so it is almost like I have to sit there and derive some answers. Excuse me, I don't think that our families or the mothers or the fathers will be so assertive. There are people who are half Google doctors who will definitely ask 100 questions. So I would like to hear your experience. I'll start with Elizabeth, then Dr. Rajesh, and then Renuka. That are we really listening to this pediatric and neonatal population? I'm not talking about the patient. Now, the people who are supposed to be their voice. We can only become their voice if we know the entire story. And that story can only come from parents. And if we don't engage with them enough, we don't know them, right? Unless they are little older, like if they are like 7, 8 and above, maybe they can answer some questions. So, Dr. Rajesh, over to you.
So, ma'am, I was fortunate enough to, work with kind of consultants who are basically they give more time and more develop, more connect with this category of people. So, see, ma'am, if I talk about our like MBBS journey also, starting from medical graduation and then post graduation. So, we during our pediatric posting, it's the longest history which we take from the this kind of a age group. In adult or even any other age group, this history is very small, but in pediatric it's like 4 page full history. So this makes you itself, to to have a attachment with the patient and their parents. So that's I think it's a basic training only that makes you connect with the this kind of. So I think during this consultation also they make them, they connect with the parents and they understand their feelings, because they understand. See, the empathy is the most important thing. So if you, and I have seen personally also that in a pediatric consultants, this characteristic is very much developed. So this is my point of view.
I think you are reminding me, my son's pediatricians, the two pediatricians, he had only two in his end during his that age group. They were all very good. They were very patient. So I purposely asked that question, whether that set of doctors, are they different from the other set of doctors? Elizabeth, what's your take on that?
Yeah, ma'am. One thing I should say is that we cannot generalize actually. There are excellent doctors, like as we mentioned, with all the kinds of engagement with the patients as well as the family members. We can see many multiple doctors like that who are going deeper into their concerns and answering to all their doubts. But there is the other version also where they are not that much interested in getting involved into the patient care, both the nurses as well as the doctors. So there are exceptions. That's what I am seeing in our hospital setting also.
Okay. Bensi is telling that I am proud to say that our pediatric nurses spend most of the time with the primary caregivers, even our doctors too. Fantastic. Congratulations. So I think that's what Dr. Elizabeth is telling. There are a set of doctors who are very good in the true sense at pediatricians or neonatologists. And the neonatologists I have personally experienced, they are very, gentle people. And neonatal intensivist also, they tend to be gentle, unlike the adult intensivist. I have huge experience with adult intensivists. There are very few intensivists who have a lot of patience. Rest of all of them are like a little on the hyper side. But anyway, today's day is not about talking about them. We are talking about pediatric and neonatal. Now let's move on. Renuka, what's your experience about my question? Are we engaging enough the doctors and the nurses? Do they spend enough time to understand? Yeah. Please unmute and speak.
Yes, ma'am. In my doctors and nurses, they are very friendly with the family when they are coming, and then they are even continuing. Still, 13 years I'm here only, ma'am, in a continental. Still, patients are same doctor they are seeking, and then they are coming, and then when they come also, they are visiting NICU nurses and then going. Those who are the seniors, the rapport we are maintaining. Even some other nurses call for the baby's birthdays, and they are going, and then that much rapport they are maintaining. And then even the ma'am, when in a baby is in ICU, mother has to come from the ward to the NICU for the QMC or breastfeeding express and see the baby. They will very goodly, they will maintain the rapport. They will receive the mother very carefully, and then they will take, if a mother is scared to see the baby or hold the baby, the nurse, NICU nurse, will give a moral support to the mother. She will calmly make them to sit, and then she will wrap very swaddling the baby very nicely, and then giving to the mother. She will be with the mother, and then that the mothers will very connect with the nurse. Oh, that nurse is so nice. She has meant give me my baby very nicely. They will talk, and then they will give a feedback it, ma'am. And then as Elizabeth madam says, there are both are there. There is a doctors who really interested them to take care of them. There are the nurses, and then doctors, as they are not showing much interested to involve their personals or their life, and they only communicate what is going on the baby, and then what is the improvement. That's only they can show the interested to talk.
I had one more question, Renuka.
Yes, ma'am.
One more question is about this is also to the audience. Huh? Humpty Dumpty Polaris assessment tool has been told to be not the best fit for neonates. So it is being recommended that you should have you can use, that's the closest that you can use in NICU, but you actually need to strengthen it with additional checklist to identify more risk in the patients. So I would like to hear from the audience whether you are using any such additional checklist apart from the Humpty Dumpty fall risk assessment, because it does not fit in for neonates complete.
Yes, ma'am, I agree with you. But we modified the checklist according to the our protocols, and then even the checklist also we have it, ma'am. And then bedside
Anyone,
checklist.
anyone in the audience would like to talk? Anything, Elizabeth? Do you have anything to?
Ma'am, we there is a standardized tool known as NAFRAT, that is a newborn fall risk assessment, which is a standardized one,
Hmm.
and that is a mostly adopted thing which has been followed in many of the hospitals we have seen.
Okay, NFRAT.
Yes, ma'am.
Okay, and where is that tool coming from?
It's actually developed by some the Boston Children's Hospital, ma'am, and
Oh,
it is adopted in US. So
okay.
that includes various factors of this maternal factors, especially as we discussed the fatigue, the sedating medications, and all the infants, the gestational age, the prematurity, and the environment also. It is cluttered, the bed height, lighting, all these parameters have been covered. This.
Any of these tools also include the mother factor there?
Yes,
Some.
yes, ma'am. This NFRAT has.
Okay, okay. So I think that's a good information to all the people here, is that please look at the tool called NFRAT. And so that I am not neonatal nurse, so I had no idea. So I'm just asking simple operational question. If Humpty Dumpty cannot reveal the fall risk of a neonate, there must be something. So thank you, Elizabeth, for that information. So I'm just trying to read the okay, by educating the caregivers in the adult patients have reduced the number of fall. Yes, we know that. There was hesitance from the attendants to call us for help. After educating, it improved. Same way, it will help this group too. Totally agreed, Vinci. Mother training during the hospital stay and competency check before discharge of patients can help patient safety at home also. Yeah, I think that is what Renuka mentioned as teach back. So when we train anybody, there is no guarantee they understood anything unless they can actually tell us and probably demonstrate also that how they are going to swaddle the baby, because I have read stories that they swaddle the baby. And if it is not wrapped properly, the cloth is in your hand and baby is down. So I have read stories about that. I mean, it's just coming back to me now that I'm talking, because unfortunately, when I was in Fortis, which both Fortis when I worked, we did not have any mother and child unit, so I didn't have the chance to get exposed to that also. So it's going to be 8:30. Thank you so much, all of you. I want to hear from all the three speakers. What are your last thoughts? What should we be doing more to ensure pediatric and neonatal safety? I know we all of us are doing a lot of things, but from your own experience, what more we need to do? Dr. Rajesh?
Yeah, so ma'am, again the same thing, that empowering, educating, and giving more attention and showing more empathy to this kind of age group is very much important. So this is what I feel.
Empathy factor can be extended to all patients, correct? Yeah.
Absolutely, absolutely.
Okay. Yes, Dr. Elizabeth.
Ma'am, I would suggest that this we have to identify the supporting system, because as we already rightly mentioned about this fall and all those kinds of things, when the mother is fatigued, the tiredness, all these are causing the various errors for the patient or the baby. So what we should see is that the supportive system we have to assist, and whether they'll be able to take care of the baby. So as in my presentation also I've mentioned about this postpartum paternal depression. So even the fathers are reluctant to take care of the baby. So such kinds of additional support has to be extended, and to see that the family, the holistic care is being provided and comprehensive assessment has been done, and thereby preventing certain kinds of errors and maintaining the patient safety of the baby.
Sorry, my puppy was distracting me. Thank you. I'm very sure that the new word paternal depression. I'm not
Postpartum depression.
postpartum, not surprised because paternal leave started. So paternal depression is also possible, very much possible. But there are some great stories. I don't know, because of the social media, you see fathers giving kangaroo mother care. And they
Yes.
actually, bring up the child by exclusively providing the kangaroo care. So we have Ranjit Nirala on the video. Do you want to share something? No, you are only watching us. Okay. So I think, Renuka, what are your last thoughts?
And then campaigning for a newborn, for fall preventing modules we can create, and then continue monitoring, checking, and then rounding the baby. And when your nurses are moving from the baby to here, they have to replace another nurse, and then carefully they have to move out from there. And when they are transferring the crib to the mother also, they have to be very careful when they are giving to the feeding time also, ma'am. And then building culture is of safety.
Thank you. I think today I have been educated a lot in the pediatric and neonatal safety. Thank you so much, Dr. Rajesh, Dr. Elizabeth, and Renuka.
Thank you.
Many different aspects have been covered, and I think there are a lot more that we need to do. Uh, we use Brad and Q. What is that Brad and Q? I know choose, that is for your early warning score for children. I've heard about that. I don't know what is Braddock Q. No idea. So I think also at national level, and also keeping in mind that most of us are from corporate sector and probably from major cities. But if you are working in any smaller cities and you get all kinds of population. So my only request will be, do not focus only on the people who are shouting and asking for attention. Those who are keeping quiet, not asking, also must be attended to, because that's our job to feel that what they would be needing, and allowing them to feel, you know, courageous enough and say that, telling them that you should ask question, you must ask question. It's for your own child's benefit. So it's very important. We are not trained to ask every time that, whether it is a doctor or anyone. Once you have explained everything, do you have any doubts? Can I clarify something with you? We are not used to that. We kind of, just vomit. I usually say, we go and vomit whatever we have inside, and we assume that they understood everything. And that is the problem, not only pediatric and neonatal areas, even in adult, it is the same thing. So it's a family and patient engagement is a big topic in WHO, and it was one of the focus areas in the one of the earlier WHO Patient Safety Day, family and patient engagement. So that discusses in details that why is it important. I think if we make them our partners, lot of safety parameters will start actually getting better rather than getting worse. I think all of us agree with that, right? So, with that note, I would say thank you everyone for being here. And very special thanks to Dr. Elizabeth Workey, Dr. Rajesh, and Renuka for supporting us today. Zoom has started giving hearts and thumbs up. It's all flowing up there. Whenever the Zoom gets updated, they give us something nice. So, nice to see hearts. Thank you very much. Oh, there's a lot of hearts coming up. Okay. So people loved your talk, and maybe all promise to be the safety warriors for our patients, the little ones, the pediatrics, and the most vulnerable, the neonates and the preterms also. I have not heard of preterms falling, but preterms, they have a different set of safety requirements, I think. Thank you so much. And have a good day, all of you. And this is a patient safety month. This is for us to be sensitized and once more reminded that we are all here. And I always say, all roads in healthcare must lead to patient safety. Otherwise, there's something wrong in the road that we have created, right? So, with that note, thank you everyone and good night. Shabak khair. Thank you.
Thank you. Thank you, ma'am.
Bye bye.
Bye.
Thank you, ma'am. Thank you
Bye.
so much. Bye bye.